Welcome to the Commonwealth Club. I'm George Hammond, Chair of the Humanities Forum, which organized tonight's event in connection with the Lundberg Institute. This is the 10th annual Lundberg Institute lecture at the Commonwealth Club and the first online one. This is part of our online series at the Commonwealth Club, and we welcome all of you as our virtual audience and also those of you who listen later. We have a great lineup, thanks to Dr. George Lundberg, of doctors who have spoken for us before here. And we are going to cover how a large number of issues, but how the COVID crisis is going to affect the whole medical system. And I'd like to introduce now Dr. George Lundberg, the founder and president of the Lundberg Institute. As I said, we've been doing this for 10 years together, and George Lundberg has a great and long medical career. He was the executive editor of JAMA for many, many years, and has done so many things in the field since, and is a thought leader in the field, and he's brought together others for this event. Thank you very much, George, for joining us again.
And thank you, George, and thank you, Commonwealth Club of California, for providing the venue and the long collaboration with the Lundberg Institute, 10 years of the annual lecture. On behalf of the officers and the board of directors of the Lundberg Institute, I welcome you, the audience, to our first ever Zoom presentation from TLI, the Lundberg Institute. I'm an academic pathologist with a long professional career with a bunch of universities, but I've been a full-time medical editor for about 40 years, if you add them up. 17 years, though, were running JAMA and all the AMA journals, and now 17 years with Medscape from WebMD. Tonight, we are joined by 4 of the Lundberg Institute lecturers on Zoom. In 2012, Dr. Donald Berwick presented the second Lundberg Institute lecture on A Bright Future for Healthcare. Is it possible? A longtime Harvard professor, Dr. Berwick is best known for founding the Institute for Healthcare Improvement some 30 years ago, or thereabouts, where he is still president emeritus and senior fellow. But perhaps he's actually best known for that a little less than 2 years that he ran Medicare and Medicaid for President Obama. In 2015, Dr. Elizabeth McGlynn, here shown as Beth McGlynn, was one of a panel of 3 speakers representing the Institute of Medicine of the National Academy of Sciences. The others were Dr. Irma Mala Sarkar of UCSF and Dr. Kathy McDonald of Stanford, who has recently moved to Hopkins. The topic was patient safety, getting the diagnosis right. Dr. McGlynn is now Vice President of Kaiser Permanente Research in Pasadena, Executive Director of the Center for Effectiveness, Acting Dean for Research and Scholarship of the Kaiser Permanente Tyson School of Medicine. We've often had books related to this particular presentation, and here's the book from the Institute of Medicine called Improving Diagnosis in Healthcare, a tremendously important book of about 500 or 600 pages, and that was the core of what she was representing. In 2016, Dr. Lena Wen, at that time Commissioner of Health for the City of Baltimore, spoke on public health and physician activism, lessons from Baltimore. Lena is now emergency physician and professor of health policy at George Washington University. She's a columnist for the Washington Post and an on-air medical analyst for CNN. Lena signed books back then. The book was When Doctors Don't Listen. I'm sure it's still available. I don't think she can sign it tonight because we're sort of long distance, but there you go. In 2019, Dr. Kenneth Kaiser, who also is on the board of directors of TLI, has been from the beginning, thank you, Ken, has had multiple careers. He's currently Chief Healthcare Transformation Officer and Senior EVP at Atlas Research in Washington, D.C. Before that, he was a professor at the University of California, Davis for a long time. He's run the Department of Health of the state of California. He's run the California Cancer Registry. He's boarded in about 6 specialties. I don't understand this guy at all, never have, even though I've known him for a very long time. But he's best known because he ran the Veterans Administration Health Service, and he turned it from a problem area to a very good area. And then, of course, he left there. His lecture was Normalizing Health Quality Care, or correction, Normalizing High Quality Health Care, Looking Back and Moving Forward. The credo of the Lundberg Institute is one patient, one physician, one moment, one decision. Let it be a shared decision, informed by the best evidence and taking cost into consideration, no matter who pays the bill. Former Surgeon General C. Everett Koop helped me get the thing started, and he loved the idea of the business of shared decision making. At that time, it was not quite revolutionary, but almost. Now I'm happy to say that it is a fairly common event. Perhaps not common enough, but it does happen. The TLI speakers and their topics, which comprise a veritable history of American medicine in this decade, 2010 to 2020, also include the first lecturer, Dr. Elliot Fisher, professor of medicine and community and family medicine at Dartmouth, who spoke on achieving a sustainable healthcare system. What might we do? He told everybody about accountable care organizations and how they might help. After Dr. Berwick, we were addressed by Peter V. Lee in 2013, executive director of Covered California. And he came to tell us about how he was going to get everybody in California on Covered California if they weren't covered another way. And he's still doing that. I'm really impressed by him. He was the son of one of my old-time colleagues at USC, actually. In 2014, Dr. Atul Gawande, professor of surgery at Harvard Medical School and Harvard School of Public Health, talked on the Checklist Manifesto and Being Mortal, Medicine and What Matters in the End, an inspirational and practical talk from his influential book, Being Mortal. Atul has gone on to do a whole lot of other things since that time, as you know, in addition to having his long-standing column in the New Yorker, which has been so influential. In 2017, Dr. Elizabeth Rosenthal, an internist from Harvard, and then a writer for the New York Times for a long time, including out of Beijing, is now editor-in-chief of Kaiser Health News, and she spoke on deconstructing America's high-priced health care. Many frankly appalling lessons of America's healthcare system grifters leeching money from all of us, as described in her book called An American Sickness. She also helped all of us present try to figure out how to protect ourselves from our healthcare system's grifters. 2018, Dr. Gary Taubes, a Berkeley-based best-selling author, talked about the case against sugar. Gary made the case that world obesity and world diabetes, those other pandemics, come more from what we eat than how much we eat. Sugar. I had his books on Kindle. I could show you my Kindle, but I don't think that would help much. So I'm not going to show you Gary's book. Tonight, our panel addresses American healthcare. What's left after COVID-19? I have a bunch of questions. I intend to mix them up and address each question to one person, but that doesn't mean that only that person will be the answerer. We might get through all 10 questions, and we may not get past the second one. I don't really know. We'll try to find out what people think and try to make it entertaining as well as educational, and us have good fun in the process, because that's really the best way you teach. So let's start with number one. And this is aimed at Dr. Donald Berwick, who used to run Medicare until the Senate said, I don't think we're going to confirm you. So he quit, did a preemptive strike, and went off to do other great things. Here's your question. What number of inhabitants of the USA were uninsured on January 1, 2020? And what number do you expect to be uninsured on December 1, 2020, when we're about 11 months into this COVID epidemic? Don?
I don't know exact numbers, George. The number I carry around in my head is about 30 million people. 27 to 30 million people were uninsured at the beginning of this year. I can't help mentioning that the nadir of that number, the highest level of insurance, was in 2016, so it's steadily eroded since then. Right now, we have two problems, at least with insurance. One is COVID and the loss of employer-based coverage, covered for a while for many people by COBRA coverage, but there's a gap for people to fall into, and they are falling into it. In addition, we've had a pretty systematic erosion of Medicaid through policy and programs in the Trump administration. So it's climbing. I would not be surprised if we have a couple of million more people uninsured at the end of the year than we did at the beginning. And of course, the future after that depends a lot on politics.
So you think the fall off will only be in the couple million range?
I think so. There are some safety net options. We've also had a couple of states now expand Medicaid. 2 more states or 3 more states are in line to do that. We have 12 that haven't expanded, but that's helped a tiny bit. So that would be my guess, but I don't know. Also, it depends.
Anybody disagree with that? What I would consider pretty optimistic number.
Well, I would ask Don if he would prognosticate on the Supreme Court and the Affordable Care Act and what might happen and what under kind of the worst case scenario, what that might mean.
Potential disaster. The Affordable Care Act, when the Affordable Care Act was passed, we had 50 million uninsured in the country. And by the way, we're not counting underinsurance. That's a different but a closely related topic. People whose policies don't actually meet their needs when they finally have needs, and that's probably also in the order of 50 million people. Affordable Care Act made major gains. We added about 22 million people to coverage by expanding Medicaid and through the exchanges and subsidies. So that cut the number of uninsured. It also made insurance more effective because insurance companies came under requirements about not having lifetime limits on coverage, reducing out-of-pocket exposures, and so on. So coverage improved quite a bit. If the Supreme Court were to strike down the Affordable Care Act, I actually can't picture how that would be implemented. There are major structural changes in the way healthcare is now supplied, healthcare insurance is now supplied, and it would be extremely difficult to unwind it. So I don't know, Ken. I'd like to know what you and my colleagues think about that, but it's not pretty. The other thing to remember is the Affordable Care Act did a lot more than extend insurance. It had a lot of provisions to improve quality of care, a lot of provisions to increase transparency and accountability of insurers, major programs on getting people out of institutions into their own homes. It expanded coverage prevention in both eventually in the commercial and the public side. All of that would be at risk.
Let me segue this to Dr. Leana Wen. Kind of an add-on question from that one. Is Medicare for all made more likely because of COVID or less likely because of COVID or neither?
It's an interesting question, and I'd be curious to hear what everybody else has to say about this too. I will say, starting off, that I am not, I don't know if you turn to me for this reason, but I'm not actually a proponent of Medicare for all. I'm a proponent of universal health care and thinking through various ways of getting there. I'm also, I think by temperament, I'm much more of an incrementalist and building on what we have with the success of the ACA. I mean, I went to medical school in the early 2000s when there wasn't the ACA. And actually, that's why I entered the emergency department and came and started working in the ED as my specialty, because I didn't want to turn patients away who didn't have access to healthcare. And so I think building on what we have is the right approach. But that said, I think because COVID has it's been this tsunami. I think that's even an understatement that none of us could have ever anticipated. And so it's really turned our world upside down. And I do think that it's in times when our entire social structures have come undone, that it is a time for a revolution. And I think that those who are proponents of the revolution and starting over, if you will, I think there'll be a lot more traction. Now, because again, I'm a pragmatist and incrementalist, I look at the patients who are in need of care right now. And I do fear that when we turn everything upside down, when people need care the most, that those who are going to be hurt the most are those who are already the most vulnerable. But
Okay,
that said,
Dr. McGlynn, uh, what about it? What if the Supreme Court actually throws out all parts of the Affordable Care Act? Would that make Medicare for All a cinch or such, because so much disaster would happen? Or would we just have to build it back incrementally to where we are, or where would we go?
Well, of course, we won't know the Supreme Court decision till next spring, and I suspect a lot of what the next steps are hinge on the election results and the, you know, in one scenario, if Vice President Biden wins and the Democrats take the Senate, you have a very different pathway than if the election comes out another way. And you've got some runway while the Supreme Court is deliberating to determine what the options are. And I imagine that it will be, I'm kind of with Lena, I'm more of an incrementalist. I mean, I am hoping, I guess, and maybe it's just because it's too terrible to imagine the alternative, that the system won't be completely blown up. I think COVID has revealed how critical insurance is for people, and I think has made it, it's leveled the playing field in some ways in terms of people being touched by these challenges. So my hope is that we would have some time to begin stitching things back together and, you know, in anticipation. But I think a lot hinges, frankly, on the outcome of the election, what the pathway is. And I'd say one more thing. I don't, you know, Medicare for All is one of those terms that means a lot of different things to a lot of different people.
Exactly.
So I suspect a lot of it depends on kind of what you mean by that and what those components are. But I think it's a little hard for us to imagine going backwards from, horribly backwards from where we are. I just
Right.
don't
Well,
know that the public will tolerate that.
okay, let me just, before going on to the next topic, say that nobody ever seems to talk about Medicaid for All, and yet Medicaid for All makes more sense than Medicare for All in a lot of ways as you build on it, and yet somehow that doesn't seem to be in our lexicon. Let's go on.
George, can I
George-
just say one thing about Medicaid, which is, I mean, I do think one of the interesting things about the Affordable Care Act and the current situation we find ourselves in is that the stigma that had been attached to Medicaid has really decreased quite a bit, and people are seeing it in a much more positive light. So I think you could be onto something. I'm just, you know, just wanted to say I don't think we should walk away from that as a concept.
That's a really good point. Its stigma is different now.
So George, let me, I actually proposed that at a large meeting a couple of years ago, you know, having run the largest Medicaid program in the country for many years. And I was thoroughly trashed by all the other people who were on the dais, as well as much of the audience. But I still think it's not a bad idea. And you know, here in California, we added 14 million people to the Medicaid rolls, which is more than all but the entire population of 3 or 4 other states. So it can work, and it can work well.
Right. I just wanted to bring it up so that the audience would get an idea that, well, maybe they haven't thought of that, but maybe they should. Let's move ahead. Back to Dr. Kaiser. Yeah, but I mean, we're into this thing, Wuhan, December, and then January, and then everybody was talking about waves and waves and waves. And then somebody said, well, we never got out of the first wave, and that every state has its own wave. But what is your best take on the concept of waves of COVID infection over time in our country, past, present, future?
Well, a couple of things I would say off the bat is that I don't know that waves has as much relevance here, since we've never really gotten the epidemic under control in the US. So I'm not sure it has as much control or as much meaning in the US as it might have in some other countries that did a you know, much better job of controlling it. I think the second thing I would say is that I would anticipate that we're going to see a huge increase in cases over the next several weeks. I think a confluence of circumstances, what's happened at the colleges, what's happening at schools, some of the Labor Day, some of the rallies, multiple different things are going to contribute to what I would anticipate. I hope I'm wrong, but what I anticipate is going to be a really large increase in the number of cases over the month of October and probably November. And I think we're beginning to see that over the last week.
Anybody react to that?
I agree with Ken. Boston just went into the red column, eight cases per 100,000. And I think Ken has exactly right. Whether it'll be in the next few weeks or the next month, I don't know, but I think we're headed for a surge.
I would guess nobody disagrees with that. I mean, when we set this up, we were going to be talking about after COVID, but I don't have the slightest idea when after COVID might happen.
When it will be, yeah.
Okay. On that nice note, let's talk about this one. Dr. McGlynn, what is the best way to balance the risks of SARS-CoV-2 infection versus the harms of isolation?
So you've picked the only doctor on the panel to ask that question of.
I think you could be objective.
Oh, okay.
You're inhabited in Southern California, where somebody wants to open up, somebody doesn't want to open up, and
Right.
Even your counties are different.
Right. Well, I mean, I think that we have not hit the right balance yet, and I think I will say that my general sense is that we, if we had, and it's easy to kind of look in the rearview mirror, but if we had locked down more seriously and stayed locked down early on, I think we would be having a very different conversation today. I do think this question about isolation and particular groups that are experiencing isolation, the elderly, I think adolescents are having a very hard time with the situation that we find ourselves in. And so I do think that that those factors should be taken into account. It would be helpful to have to be able to lean more on science as we make these decisions, and to find some creative ways, frankly, to address the issues like isolation and loneliness. I mean, I think we should take quite seriously the mental health effects associated with the situation we find ourselves in. And I think everybody probably on this gathering tonight has probably had frustrations with the things that we can no longer do, and find some of what we are engaged in very challenging. I mean, I'll just say, when we went out on lockdown from work, I thought we'd be out for, 2 or 3 weeks. I didn't give it a lot of thought. And so I think the uncertainty attached with not knowing when we're going to get out of it has made it really hard for people to cope. So I don't know that we found the right balance yet. And unfortunately, I think we lost some ground early on that has made it even more difficult to find that balance.
Don, what do you think?
We have a public health specialist here.
Yeah, I was going to say.
Lena, I have I think a couple of things. This is a very patient virus. When we act impulsively, it just waits, and then it will come back and get us. And we've got to be long-sighted and scientific about this. So short hits are not going to be valuable if we concede to worsening of the pandemic. We've got to take a long view. It's very hard in this country. Everything feels so emergent, and the economic pressures and so on. But I really think we need a plan. We don't have a plan right now, and I think that would really it's important to plan ahead. I have one positive thing to say in this very dour thing, which is we're learning so much so fast. There's so much adaptive capacity being developed in this country, both everything from the clinical end about how you care for these people that are affected, to understandings of testing and treatment, eventually the vaccination regime, but even beyond that, how society can adjust. And I think we're going to know a lot about how to mitigate some of these effects. We're going to gather a lot of knowledge. My biggest concern are, of course, for the marginalized populations, for isolated elders, for people with at the lower end of the income spectrum, and we need a compassionate governmental response to help mitigate the effects on people who are most vulnerable. Kids, I'm a pediatrician and grandfather of 7, and watching families adapt and what all of these incredible adjustments for families where there's work and kids are now at home, and our families can adjust. There are families that need a lot more help to adjust, and we need to get to social policy about that.
Right. Back in January, my wife would ask me, well, what do you think is going to happen? I say, wait a minute, we're learning something every day.
Every minute.
And every day more. Lena, what do you say? You have a plan?
I have a plan. Well, I have more than no plan, which is the
Current
far.
national policy.
Well, that's nice to hear.
But, I was actually thinking about this because somebody asked me earlier about what's been, why haven't we had a plan so far? And I actually thought about this, and I looked back and I saw that there actually had been a lot of plans. You remember back in April when it was announced about reopening, the White House's own coronavirus task force had a whole blueprint for reopening America. Now, we didn't follow that blueprint at all, but there was actually a plan. And I feel like everything so far that's been released, and this is not meant to be a political statement, this is just a descriptive statement, so much has been announcements and press releases. It's 150 million tests that are distributed. It is whatever number of masks distributed. It's not a plan. And I think we're seeing the consequences of that piecemeal approach. And so I very much agree with Beth that had we thought this out in advance and really had a full, proper shelter in place, and then reopening slowly and carefully, that we would not be in the position that we're in now, which I think, as Ken said before, we're entering fall and winter with many more infections coming. And so I think, to your question, George, about just how to get that balance right, I think that there are two major things. One is that we have made a mistake, I think, in somehow pitting, and I know this is not what you're doing, but just the general narrative has been somehow pitting public health versus other things. That we're talking about what's the risk of, keeping our kids out of school versus being in school, or keeping people out of jobs versus being in jobs. And I think ultimately it should be that public health and the approaches that we're using is the roadmap back.
The first editorial I wrote in Medscape about this was, might COVID blend public health and clinical medicine in America? I mean, that really ought to do that, like merge the schools, for example. Okay, let's move on. We got a lot more questions here, but next one was intended for Dr. Wen. It's a clinical question. A statement first. I consider the behavior of the American workforce during the pandemic to deserve great respect, admiration. How would you characterize the professionalism of the American workforce as displayed by this epidemic?
I mean, I think it's been exceptional. I've seen health professionals from all places, paramedics and EMTs and other people who are essential workers, to, I think Don was mentioning about how much we've learned in this process. I mean, we've evolved so much knowledge. I've seen my fellow doctors, nurses, respiratory therapists work with so little, running out of PPE, which we could never have imagined, but just seeing how much they've adapted. And so I think that, when we talk about the case fatality rate and the amount of work that's been done to save lives, that's credited to the medical profession. It's not credited to the lack of a national strategy.
Absolutely. Now let's move on from that to some of these other also very important questions. Dr. McGlynn, you protested, and not being a physician being asked a clinical question, but you did fine. But you are in charge of a bunch of research programs. So how about this question? What was and will be the effect of the COVID pandemic on clinical research?
So I think it's been an amazing time of, worldwide collaboration and speed. I mean, I don't think in my lifetime I've seen anything quite like it. And I think it's also highlighted in a way that we've known for a long time, but the importance of diversity in enrollment in trials. So as we are trying to learn really, really quickly, we can't learn just on a subset of the population. We really have to understand how, you know, prevention and treatment affects the broad spectrum of Americans, and we need to find ways to get past the mistrust that minority communities have in the research community so that we can understand what's going to work for everybody. So I'm hoping that some of the things that we've seen, the innovations, the sort of speed, really collaboration at a level I've never seen, I'm hoping we can retain a lot of that, because I think that bodes well for our future. I'll say the one thing I worry about a little bit is that we've become a little COVID centric. And so I do worry about learning in other areas being put a bit on hold, and even some of the advances that we're making that we aren't thinking broadly enough. I mean, I think COVID's been a great diagnostic and a great teacher, but if we only take the lessons to be meaningful to this disease and to infectious disease, we're going to miss some big opportunities. So I think there's a lot that I'd like to see us hold on to, and a lot to be proud of, and some cautions.
Ken?
So, George, I'd like to kind of follow up on both what Beth and Lena were saying, that while I think professionals across the board in healthcare, their performance has truly been exceptional, as was said. And I think the system, insofar as research, has done well, but I think COVID really has exposed a lot of vulnerabilities and weaknesses in our healthcare system overall. And whether you look at how specific populations have been addressed, whether nursing homes or a number of other populations, it has exposed weaknesses there. When it looks at, PPE and some of the other supply chain issues, clearly some big vulnerabilities there. So professionals have done great. Research, I think, is doing great, and hopefully we will continue along that vein there. But this does also shine the spotlight on and provide opportunities to improve the system overall.
Certainly true. A reasonable segue from the research question has to do with the creation of new scientific knowledge and the distribution of new scientific knowledge. And my question to Dr. Kaiser or Dr. Berwick, for starters, what was and will be the effect of COVID pandemic on the distribution of scientific, medical, and public health information? Don, you want to start?
Well, like Beth, I've been amazed at the acceleration of the speed of movement of scientific knowledge around. There's a canonical paper. I know the paper. I don't know why it's been so widely quoted, that it takes 17 years from bench to bedside for an average medical innovation. Beth, that's a good research project for you to pick up again, see what it is. It's 17 minutes now. It's been really, really interesting to see how fast things have moved around.
Yeah, but it's junk. A lot of it's junk. How are you going to deal with that?
Some of it's junk, but two things. First, on the positive side, we're seeing a relatively disciplined sense of curiosity in the healthcare workforce, where they're using their brains to sort the junk from the non-junk. Within, I think, a week of the arrival of the virus in Seattle, I was sent a copy of about a 3-page single-spaced document that Seattle intensivists put together, having debriefed Wuhan intensivists with hints for clinical care of COVID, and It was pretty darn good. I don't think anyone took it wholesale. I think it was subjected to a lot of critical thinking, and I trust a lot of the workforce. As far as the junk goes, yes, there's a tremendous amount of stuff being purveyed now, and that's why we need to make sure that we figure out how to put the appropriate scientific regulation, if I can call that, the ability to regulate our knowledge growth with proper science. But I am excited by the pace. Journals, your old journal, JAMA, George is turning around more papers faster than I've ever seen before. The National Academy of Medicine set up a standing committee on new infections. Usually it takes a year and a half to get that stuff going. In 1 month, they produced 11 pedigreed reports guiding care. So we're learning something about how fast
Yeah,
this
who
knowledge
was
growth
it that said necessity is the mother of invention?
That was you, I think, George. But we shouldn't lose our brand on this one. You're exactly right. We have to be able to sort wheat from chaff. But I'm more excited by the tempo than I am disturbed by the threat of what you.
I actually agree with that. Although with medical publishing or medical information, you can have it fast, you can do it cheaply, or you can be correct. Pick two. And that's a hard one. I mean, preprints. Now, I'm on the board of directors of the Friends, the National Library of Medicine, and we're hosting a program, a 2-hour program within a month on just this issue, medical publishing, just distribution of medical information, the issue of preprints, the issue of journals that are predatory, that people get trapped into thinking, the issue of going on live television was something that you don't have. I mean, it's a really, really hard deal. Ken, you've done a lot of publishing and a lot of reading. What do you think?
I would agree with Don. I think what he says is right on. But I would raise a corollary issue. And I think what this has also exposed is how far we have to go in bringing the general population along with some basic public health and other science concepts, and hopefully increasing the confidence in science among the general public. I think what we have seen with COVID, or what it has exposed, is how thin is often the level of knowledge about some of these basic concepts among the public, and the distance that we need to go to bring the overall population, or at least a significant portion of it, up to speed in understanding some of these complex issues, and also to bring the level of confidence in science up.
George, I have to leap in here about the need for leadership to honor the science, because the attack on science in public arenas by leaders, that's toxic, and that makes all this fast pace, of course, much more dangerous. I'm curious to know, Ken, brilliant leadership, the VA, did you ever experience this kind of politicization of the scientific stuff you were trying to get done, or is this wholly new?
I think it's new. I mean, there are certainly always been vestiges of it, and I can think back to my days, running health in California, where I had a lot of problems on selective issues, but I've never seen the degree of toxicity and the wholesale dismissal of science that has occurred with some of the current leadership, and how destructive that is to everything.
Right, that has not happened in my lifetime,
Yeah.
and it's so distressing. What did happen was on a single issue, the issue of guns, and some voters in San Antonio, Texas, got on some Congress people who got the CDC unfunded for studies of violence,
Right.
but it was a single issue deal. On this one, it's just a broad scale attack on science. Well, we've made our statement on that. Let's move to something that might have a little more potential hope to it, like turning a problem into an opportunity. Dr. Nguyen, the people who are likely to be prone to get really sick with COVID, as opposed to not getting very sick, and we don't really know why, but we do know that if you have diabetes or if you have serious obesity, your chances are real that you're going to get a lot sicker and you may die at a much higher rate than if you don't have that. Might we use this opportunity to try to also control COVID, do some good work on getting rid of obesity? And when obesity disappears, so does diabetes. What do you think?
I'm going to give you not such an optimistic answer. Maybe somebody else has a more optimistic answer here. I actually think that another thing that COVID has unmasked is so many of these underlying problems, right? It's unmasked disparities. It's unmasked our the problems of our employment tied to health insurance. It's tied to many. It's unmasked a lot of problems. Another issue it's unmasked is America's short attention span and our fixation on the pill for every pain, like the silver bullet. Because what actually we know, right? We know beyond a shadow of a doubt now that what we need to keep the virus in check is those hard things. It's the social distancing, the mask wearing, the reducing our risk in other ways for months, maybe for a year, I mean, for some period of time. And we're not doing that. Instead, I think there is a national strategy, if you will, that's pinned to the idea of getting a vaccine ASAP. And just kind of letting things go in the meantime. We're not willing to put in the hard work in the meantime. And I am therefore not sure, George, that we're going to be able to put in the hard work to reduce the burden of chronic disease that's actually making COVID more severe. I hope that my best hope coming out of this is that we'll have more attention on public health, the fact that public health infrastructure was not strong to begin with, the fact that local public health was decimated, the fact that disparities are a long neglected issue and social determinants all factor into what makes people ill. But whether we'll turn our attention to actually addressing diabetes and heart disease and obesity, I'm not convinced. But I stand ready to be convinced if somebody else has an alternate view.
Well, I was just looking for incentives. I mean, if you could go to the public and say, look, if you shed 40 or 50 pounds, COVID is less likely to kill you. Maybe that's an incentive.
Wear a
I don't
mask and COVID is less likely to kill you, and we're not doing that.
Well, no, but we're doing better than we were a month ago, and I
We're
think
not. We're not. If I
not
get
even
to
better.
say,
Well, maybe not better. Okay, fair enough.
no,
I
we're
mean, I
I-
think the challenge is that I don't think there's anything new about the obesity epidemic and the implications it has for a variety of health problems. But we haven't really identified solutions that people are, able and willing to embrace. And it's not, there isn't a quick fix. I mean, as Lena was saying, there's not the quickest fix may be bariatric surgery, and that's a rather significant undertaking. And so I think it really starts with it's a lifelong thing. It's easier if you can get a population not to become obese than it is to turn it around once it's happened. But I don't think there's a fast and quick answer to this. I think we know already what we need to know. I do think that we need to pay attention to our sort of general health and well-being. I'm not convinced that this is the thing that will turn it around. I wish it was. I mean, honestly, I wish it was.
Yeah, I was on a program with Tony Fauci about a week ago, and it was a small circulation program in the pathology community. But he was just shaking his head about, well, we can have a national policy on something, but then we have the implementation of this, it happens to happen on a state-by-state basis, and and of course, more than that, happen on a county-by-county basis. I have the pleasure of living in Santa Clara County, where we have a wonderful county health officer and a very educated, informed population that wants to stay healthy. Even here, it's a problem, and we're still, my wife and I have been basically sheltering in place for 6 months because we don't want to get sick. We are able to get out in controlled ways, exercise every day and all that kind of stuff. But nonetheless, the fragmentation of the country and not having one plan for overall, as a smaller country or a country with different forms of government might have been able to do. Everybody looks at New Zealand, obviously, and Taiwan and Singapore. Japan's a big country, but it's a whole different culture also. Dr. Berwick, let's come back, go to this question. I showed Atul Gawande's book earlier on. I'm wondering, has the U.S. approach to death and dying changed since Atul wrote his book, or has it changed since COVID, or has it not changed at all, or is it just happening because you get locked in a nursing home and then you get sick and then nobody can ever see you again? How are we dealing with that?
I wish I had better data, George, but I have an impression. I'm happy to share it with my colleagues and you. I think the water level's changing here. I think there is a just sense of maturation and more uh, more transparency about the conversation itself about death and dying in this country. Do you know, when I went to Washington barely 10 years ago, it was absolutely third rail. Nobody would talk a bit about advanced directives or advanced care planning. You still literally couldn't mention it because the fear of getting slammed politically was so high. That's not true today. There are good discussions underway in the public and private sector about that. So I guess I'm a bit optimistic about the direction this is going. I think we have
Looking
to
for
stay.
optimism here.
Yeah,
To talk about
There's
death and dying and put optimism in there with death and dying is a pretty interesting use of terms. Anybody else have an opinion that's any different?
Can I just say one more thing about this? There's a thing about this that isn't exactly what you're asking, but I'm very intrigued in the COVID era. That has to do with overuse, not just in end of life care, but we have massive overuse of ineffective care in this country because it's been reinforced by the fee-for-service system. Now we've had this period in COVID when you wouldn't go to the doctor. People aren't going to the hospital. And there's a very interesting thing playing out in the research community, which I hope develops fast, about what did we just learn? You know, there's certain, like if you probably have an ST elevated myocardial infarction, probably should go to the hospital. But there's a whole bunch of stuff that we've learned through decades you have to do that it turns out you don't have to do. And I hope there's a vigorous research enterprise
That's
there.
a little bit like Beth is down there in Pasadena. When I was at USC as a pathologist, we had a doctor strike in California over the malpractice issue. And during the doctor strike, the data showed the death rate went down.
Yep.
Significantly down. So I don't know. Okay, meanwhile, back to Dr. McGlynn, and all of you can deal with this one. It's been one of my favorites, and it's not simple. None of these things are simple. But how has education of the general public, and for that matter, physicians, about the diagnosis of the virus in respect to the concept of accuracy, specificity, sensitivity, predictive values, false positives, false negatives, pre-analytic factors, post-analytic factors, interpretation of this, predictive value depending upon prevalence of that particular disease in that community. Doctors have trouble with all of those concepts now. I first published about this in 1975 when Ray Gambino came out with a book called Beyond Normality, which introduced the doctors of the world to the concept of sensitivity and specificity. They still don't understand it, although they're doing better, I think. What do you think, Dr. McGlynn? You were on that whole group about diagnosis at the National Academy of Medicine. Are we making any progress?
It's a great question. I mean, I do think on the one hand, we've had this, what I call a national teach-in of epidemiology 101. So, and I, never have epidemiologists been so much in demand by the major news networks. It's like their moment in the sun. So and I do think what it's meant is that the public has become more familiar with some of those terms. But the bottom line is, I'd say there are a couple of things. One is the concepts are still quite complex, and I think very hard. I'm involved with the inaugural class of the Kaiser Permanente Bernard J. Tyson School of Medicine, and that's one of the things that we're teaching, and it's really interesting to try to get people to grasp that. So it's complex. The other thing is that those concepts apply at a population level, and honestly for most people it's really, what does it mean to me? And I don't think we're always really good at translating from what we understand at a population level to what it means to the patient in front of me. And so I do think that there's greater awareness. I'm not sure that the general public has a much greater understanding of, the diagnostic process, particularly the uncertainty attached to the diagnostic process and the way in which the sort of operating characteristics of the mechanisms by which we arrive at a diagnosis affect the likelihood that we've, hit it or not. And then, as we said before, I think all of that's been complicated by really chaotic communications about all of this. So I think that there's as much information, there's as much misinformation as there is information out there. So I'm not really confident that we've made a huge amount of progress, except maybe in familiarity with some terminology.
I mean, to be fair, I'm a doctor. I have a patient. I get a nose swab. We send it off for a PCR, theoretically the most specific of the efforts to find whether the virus is there. It comes back positive. What am I supposed to do? It's positive, but if the prevalence in the community is low, the chance of that being a false positive are about 90%. I mean,
Yeah,
really.
so, but what we know today is that we should just assume, test or not, that everybody has it. I mean, the only way that we sort of, this is really Lena's territory, but I mean, the way we stop the virus is that we, that information can be helpful. If we had a fully functioning public health system, we would be able to take steps to contain those, sort of known cases where we have some reason to believe. And so, I mean, and I agree with you that the prevalence really affects how much confidence we have. But in many ways, I'm not sure that changes what we should be doing. And if we just acted on those, maybe it means some people get isolated that didn't need to be isolated. But honestly, if it stops the spread, it's worth it.
Put your mask on.
Put your mask on. Yeah. But Lena should really answer that.
Lena?
Yeah, if I can, I maybe less on the specifics of the epidemiological terms or whatnot, but more on just the understanding of risk. I think that there are that people, especially around reopening and what people can do, are misunderstanding a couple of key concepts that I think are really leading to more spread. I've written about this, and I should have a column coming out in the Post tomorrow, in fact, about this as well. One of the problems is people thinking, well, if something is open, that means that I can do it all. That if my school's open for my kids, then I can also resume birthday parties and play dates and dinner parties and everything else. And of course, that's not it at all, right? That there's the cumulative risk that we should be thinking about, not the if you can do one thing, go ahead and do everything. And I think it's very hard to convey that concept to people, especially when it looks like out their window, like everything's back to normal, everybody's going about doing their normal things. So I think that's one concept that's a miss. But the second thing that's also a growing issue is that, and again, understandable why people think this is the case, but they're so much more relaxed around their friends and family than they are around their strangers. It's this magical thinking that some have called it, that of, well, people I love can't possibly have it. They look fine. But the same people who would never consider, they're getting their groceries delivered. I mean, I have a patient who gets her groceries delivered. She can't fathom going on a bus for 15 minutes, but she invites her friends and her family over to have indoor dinners together. And it's because this thinking that, well, they can't possibly have it. But now we know that most of the recent spread is not so much in congregate settings anymore. It's in these individual settings like that. And so I actually think it's much more useful perhaps than conveying, negative predictive value or whatever to patients. It's these concepts that really influence how people live their lives.
Yeah, I assume everybody I come in contact with, even at 6 or 8 or 20 feet, is infected, and that I make sure my mask is on and distance and hold my breath as they go by. Anyway, and mostly go outside. I would guess from my clock, maybe 5 minutes before George Hammond will take over and field questions from elsewhere. 5 minutes isn't very long, but quickly stated, we'll start with Dr. Kaiser on this one. How are the Democratic and Republican platforms about health similar or different because of COVID? 5 seconds, 30 seconds?
Yeah. Well, since the Republicans don't have a platform, that's hard to answer.
It's easy to answer. They don't have one. Okay.
I mean, there is nothing to comment on there. I think as far as the Democrats, there's a much more clearly defined plan and approach that hopefully we'll have the opportunity to operationalize.
Don?
Well, I served on the Biden-Sanders Unity Task Force, and I can talk about this issue there. It was very interesting because there really are two two healthcare positions during the COVID pandemic, and as long as that lasts, position in the Democratic, at least the recommendations of the Democratic Party, of I would call a very generous view of coverage, completeness, 100% coverage of costs of COVID care. It's sort of an example of the country really reaching out to people to everyone, including people who are vulnerable during the emergency. Then there's a second component, which is a more moderate view of what the steady state could look like. As Lena said earlier, trying to move toward universal coverage, not quite getting there, but they're using the public option, encouraging states to expand Medicaid and so forth. So you actually get two views of public policy within the Democratic platform, at least as the Unity Task Force recommended it. On the Republican side, like Ken said, I don't know. I haven't really seen anything I would call a plan or a policy play out, except to devolve a lot of the responsibility in COVID to states.
Dr. Nguyen,
Yeah,
any comment on what the platforms might include or how they might act, depending on how the election goes?
I mean, I agree with everything that's been said. I would just
Okay.
say that there is a unique challenge for if Vice President Biden ends up becoming the president, which is that he's facing an incredibly polarized country. So as great of a plan as could be written on paper, how are you literally going to get people to abide by, for example, mask mandates? It's very different than, I mean, his plan, and I've written about this, that his plan would be great if it were implemented in January of 2020. But if it were implemented in January of 2021, it's a whole different ballgame.
Yeah. Dr. McGlynn?
Yeah, I'm not sure I have anything to add. I do feel like healthcare is something that Americans, the public, the general public, agrees about more than they disagree about, and it would be lovely if we could find a way to use that level of agreement to find a path forward, and be able to really make some progress, because it's just so critically important. So my hope would be that we find a path to solution, and that we use this lesson that we've learned to motivate us to find those solutions.
I like that as a
George,
closing statement. Yeah, go ahead, Ken.
Oh, I was just going to say the last little point I would make, and what we found in lots of other issues like this, is that we need to reframe and recast the whole argument. We need to think about it in a different way than the way it's been presented and argued over the past many months, and whether that's casting it in terms of patriotism or, there's a number of other ways that it could be done. But I think the issue has to be reframed if we're going to have a new start.
There's a great I live in the Silicon Valley, and we make a lot of machines out here. But there's a great feature that a lot of them have. It's called the reset button. If you can find the reset button, man, that's great. But I don't know how you do that with human systems. Meanwhile, back to Mr. Hammond. Have any of the people out there seen fit to ask any questions?
Absolutely. And there's a lot of questions about, and on both sides of the issue, about the potential vaccine. As you know, the internet is filled with all kinds of ideas about this. And is there anything, some people are saying, is there anything you can say that will calm down that group? And the other group is saying, is there any way to trust it? And I think that plays into what you've been discussing. One of the big issues is, how do you get the whole population, or at least a large amount of the population, to cooperate with any medical system that's on a vast scale? So if you could say something about the potential vaccines and explain why they might not have microchips in them, that would be useful.
Don, you're the pediatrician. Maybe you'd like to deal with that.
I was hoping you wouldn't pick me.
But you don't have to. Anybody else? Nobody seems to jump.
This is the learning system we talked about. First, in the scientific end, we're seeing an immense engine. Where I think it's 160 vaccines was the last number I read, currently under development, and there's going to be success out of that. I think it's going to take longer than people hope, certainly than I hope, but I think we will see the emergence of something that's going to be as effective as, well, not as effective as we want, but at least as good as the flu vaccine. However, a lot of this depends on the leadership issues we talked about before. We're going to have to build public trust. around the integrity of this component of the public healthcare system, and that's been severely eroded. And of course, people are, when you hear different leaders giving different signals and yelling at each other, and some obviously irresponsible stuff going on, of course the public will not trust what's happening. So we have, I think there's a sequence here, which is restore public trust in the scientific integrity of the vaccine endeavor. The other one has to do with commitment to equity, because this is an international issue. The United States withdrew from the international sharing regime for vaccines, a very, very unwise move, because we're not going to benefit as fast as we could from developments in other countries, and we're going to have to return to some sense of morality in terms of ethics as to who gets access to the vaccine when.
I just want to weigh in on something that Don said, and some of the work I'm doing is somewhat involved in the vaccine issue, but and a conversation I've had probably at least a half a dozen times in the last week has to do with the effectiveness of the vaccine, and that people seem to be stunned to learn that the vaccine, whichever one may become the candidate or the candidates that are used, may not be 100% effective. And understanding it, Don was saying as effective as the flu vaccine, which, is not 100% effective by any means. And so building some understanding both in the trust in the system that it'll be safe, but also understanding or having realistic views about how effective a vaccine can be and what some of the limitations of vaccination will be, even when one is available, and the need to continue with some of the other practices.
Yeah, I was going to say that it's just going to be one tool in our toolbox, and it's unlikely to be. I think the thing that worries me is people are pinning all of their hopes on vaccine, and then everything can go back to the way it was before. And I think that's highly unlikely anytime in the near future. So I do think talking about it as adding an additional tool, and also paying a lot of attention to communications with and radical transparency around the science. I mean, I just think that and a commitment to keep politics out of the approval process. I think we have to do all of that. And it's still, I think we have a long road ahead.
I was very pleased to hear Bob Redfield, who's been under attack from every way, a lot of times for good reason. When Bob, we go back to the 80s and HIV days, and I've always respected the guy, but I was pleased when he came out about a week ago and said vaccine effectiveness might be about as effective as wearing a mask, although maybe not as effective as wearing a mask. So maybe if you do them both, you'll be in pretty good shape, but don't give up the mask.
Lena, one last comment here for us.
I was just thinking about this issue of vaccine hesitancy, and there's already a group, right, a baseline that is skeptical of vaccines. They are skeptical of science. But now you've added on top of that a group of people who are really skeptical of this vaccine because they believe in science, but they are afraid of political interference. I mean, you have a Pew poll that showed back in, I think it was May, that 72% of people would take the vaccine. Now it's down to 51%. More than 60% are concerned about political interference. And so I totally agree with everything that's been said. I love this idea, Beth, of radical transparency. And I think at the end of the day, it's not so much going to be the president or whatever elected official saying, take this vaccine, it's now approved. It's really going to be up to individual physicians making the recommendations to our patients. And we're not going to make those recommendations unless we trust the vaccine. And ultimately, for a vaccine to be effective, it doesn't just have to be effective and safe, it also has to be trusted. So
that's a great point. And I think, oh, thank you very much for joining us, Lena.
I'm sorry that I have to go. I have to put the baby to bed. Thank you. Congratulations, George.
Bye-bye, Lena.
Thank you very much.
So another question that came in that's related is the diversity of all of the vaccines. I think, Don, you said there are 160 that are going on. What does that say about how medical knowledge has spread around the world, how all these different places have been developed, and that the person with the best vaccine might be some medical facility in Nigeria or something like that? I think maybe it's going to be one of the first demonstrations the spread of scientific knowledge around the world in everybody's institutions. That's sort of the framework of it. Does anybody want to talk about that shift? Because that shift is a fairly recent shift, that there's so much research being done in other places. A lot of people think, oh, all the knowledge is being figured out in America and Europe, and that's not true anymore. And I'd like to have you all talk about that just a little bit.
Now, I mean, the U.S. no longer has a monopoly on the biomedical research enterprise. There is very stiff competition from both West and East. And I think we have to understand that the world is very changed in that regard. And so at the moment, we don't know where the major breakthroughs are going to come from.
I
That
see
might
this.
be I was going to say that might be competition from a financial point of view, but from the consumer point of view, from the population's point of view, that competition should be a good thing for the medical industry, right, in the world.
Competition, but cooperation also.
Yeah.
I see this question you're asking, George, is it's sort of a breed of problem that the planet has now inherited. It's the same as global warming and climate change.
Mm-hmm.
We are, like it or not, one planet with very fuzzy borders, and things move around, bad things and good things. But in order to manage the good things, the knowledge base you're talking about, we need international institutions that we invest in, that we trust, that curate this kind of knowledge and help us all sort the best from the worst. Right now, those international institutions they're really trying hard. I personally believe WHO has done a very fine job, despite the criticism. But we need to build a kind of international curation of knowledge and support for exchange of knowledge. And you're right, George, not just so that the North can help the South in this world, or the rich can help the poor, but vice versa, because the countries that are emerging economies and lower income countries are producing tremendous amount of knowledge that we can use in the United States. But we have to think differently about the global regime.
Yeah. Beth?
No, I mean, I think the competition is, or the sort of heavy engagement is exciting, and I think we don't know all of what will come out of it. And I do think that it's unfortunate that the United States has sort of taken itself out of being part of the global community. Honestly, the path back to normal is for the world to have access to whatever is going to turn out to work. And so I think it is in all of our interests to find a way back to that kind of international collaboration. And not, many of those vaccines won't succeed, but I think it's tremendous that we have this much running at the same time, because I think as somebody said earlier, it increases the odds that we're going to find something that works, or works well enough to move us, to allow us to have some progress.
George?
No comment. Go ahead.
Right.
Next question.
So it reminds me a little bit of other scientific endeavors that took place, between the communists and the scientists are an international community anyway. And so I think that's something, even though people don't trust science, there are lots of scientists that have worked for even the last 100 years across lots of political borders to the benefit of all of us. Yes, some things, didn't work, but we certainly have gotten a great advantage out of that. And I thought, maybe that's one thing that COVID-19 will teach us. And you mentioned it, Don. It might be a nice dry run for working on climate change together, right? That we are able to work together on something that's an immediate risk to all of us when we can see a long-term risk. So George, any last comments from the Lundberg Institute?
Well, thanks to everybody for participating. Thanks for being a speaker earlier. Thanks to all of our lecturers who are out there watching, even though they weren't able to be with us. And thanks to our audience. Thanks to George, our gracious host, and to the Commonwealth Club. And be healthy.
And safe.
Thank you.
Thanks, George.
And so ends another event at the Commonwealth Club, the 10th Lundberg Institute lecture. And it was 118 years of enlightened discussion, only 10 with the TLI, but 118 for the Commonwealth Club. Thank you all very much for joining us. Good night.